All right, we're going to get ready here in about 30 seconds. If everybody would like to take their seats, and we'll start getting organized. All right, we'll go ahead and call the meeting to order. This is the Interim Joint Committee on Health, Welfare, and Family Services, meeting number 2. The date is Wednesday, July the 20th, 2022. Madam Secretary, please call the roll.
Senator Rocky Adams. Senator Berg.
I'm here.
Senator Carroll.
Here.
Senator Givens. Here. Senator Harper Angel. Here. Senator Howe.
Here.
Senator Kerr.
Here virtually from Lexington. Can you hear me?
Yes. Senator Meredith. Senator Nemes.
Present.
Senator Wise.
Present.
Representative Bentley. Representative Bowling. Representative Bray.
Present.
Representative Birch. Representative Dotson.
Present.
Representative Elliott. Representative Fleming. Here. Representative Frazier Gordon.
Here.
Representative Marzian. Representative Gibbons-Prunty. Representative Rayburn. Representative Raymond. Representative Riley. Representative Sharp.
Present.
Representative Sheldon. Representative Tate. Representative Weber. Representative Westrom. Representative Wilner.
Here.
Co-Chair Mosier.
I'm here.
Chairman Alvarado.
Here. All right. And before we get started, I wanted everyone to note, I know we have new LRC rules about members attending remotely. However, Senator Kerr, I believe her husband is recently tested positive for COVID, so I know she's staying at home to be safe for everybody. We appreciate that. And so Senator Kerr is attending remotely today as a result of that. Also, we got a full house. I know some might be trying to find a seat. Actually, the room 131, annex room 131 is the overflow. So if anyone's trying to find a spot, they're welcome to find a seat in room 131. We've got a very aggressive agenda today, a lot of topics to cover. We've talked to a lot of our presenters, so I remind all of them, please, to keep your testimony real tight. Interim meetings are often an opportunity for us, particularly with a short session coming up, to try to address some of the bills and things we couldn't get across the finish line during the longer session. And so we want to make sure that we have an opportunity to have some discussion and some questions from the members. So try to keep the testimony tight. Sometimes the bills have already been reviewed during the regular session. People are familiar with it, but we want to be respectful of everybody's time and opportunity. The first order of business is approval of the minutes from the June 2nd meeting. Do I have a motion on that? You have a motion and a second. All those in favor, please signify by saying aye. Aye. All right, the minutes are approved. All right, the first thing we're going to take up is we're going to look at our regulations first. That's item number 8, and there's quite a few referred administrative regulations on the agenda. I've had a chance to review these. I know there's been some discussion. Some of these are regulations we've discussed before, and there have been a few changes. I believe there is on 902 KAR 010120, it's Kentucky Public Swimming and Bathing Facilities. There is an agency amendment on that regulation. So for us to consider that, we need a motion on that agency amendment. If there's anyone here from the cabinet who may want to come, who can come and testify and talk about that amendment, would be great. You could come forward, identify yourselves for the record, and just we've had this discussion about this. It's always was controversial in Administrative Regulations Committee before and in this committee as well. If you'd like to introduce yourselves, and please begin your testimony about what this regulation is and what the amendment does.
Julie Brooks, Regulations Coordinator for the Department for Public Health.
Jessica Davenport, Environmental Management Branch, Facility Section.
So we began the process to amend our swimming pool regulation probably last fall. We had a number of public comments, did a statement of consideration, an amended after comment version of that regulation. At the first time it was before a reg review, there were some additional concerns raised by the committee members, so we deferred the regulation, made some additional amendments through an agency amendment at that time. When the regulation was before reg review the second time, there was additional concerns brought by a stakeholder group. So this agency amendment before you addresses those additional concerns.
Can you briefly explain what the amendment actually does?
Certainly. Let me look at it. So there was some concern that in certain areas or certain larger pools, the buoy line that separates the shallow end from the deep end, if it were present during certain activities, it could be more of a hazard. So the first part of this amendment allows some flexibility for when the buoy line would need to be present and when it could be removed. The first agency amendment we did before reg review established gave facilities the option to do an alternative staffing plan that would vary from the requirements for lifeguard staffing in the regulation. So the second part of this and the additional concerns that were brought up before reg review addressed that. Not only did they want some flexibility with the lifeguard staffing plan, they wanted flexibility with some of the safety requirements. So through some conversations with program staff, we agreed to allow a facility that if they have an alternative lifeguard staffing plan, they could also submit for a variance of the safety requirements. So that's what this agency amendment does. And then the rest of this brings our inspection forms in line with those additional changes.
Very good, thank you. Do we have any comments or questions from members of the committee? Chairwoman Mosier.
Thank you for bringing this before us. And I just have a quick question on the alternative lifeguard staffing plan. Does this still require that a lifeguard be present at the public or state parks and public beaches? Because I know that there's an issue with finding lifeguards, right, and that's never been in place.
Right. So in terms of the beaches at the the state park, or lifeguards at the state park beaches, we did allow for flexibility with that. So that was the first agency amendment. It did change that. Lifeguards at their pools, I think, would still fall within the parameters of the regulation.
Okay, all right. But this still allows our state parks to operate? Yes, ma'am. Okay, thank you.
Any other questions? If not, we'll need to have a motion to accept the agency amendment. We have a motion. Is there a second? We have a second. All those in favor of the amendment, please signify by saying aye. Aye.
Aye.
Anyone opposed? All right, the amendment has been adopted to that. Any other discussion on this regulation or any other regulation that's before the committee? If not, we'll let the record show that these have been reviewed by the committee. Thank you very much, ladies, for your time in coming forward. All right. Let's go back to item number 3 on the agenda. We're going to talk about community mental health centers and behavioral health service organizations. We've asked the Commissioner, Commissioner Wendy Morris, to come today and present a bit of information. So I think we've got the Commissioner as well as Vestina Robbins from the Department for Behavioral Health and Developmental and Intellectual Disabilities. If you all want to introduce yourselves, even though I just kind of did, and please begin your testimony and providing us an update here in committee.
Thank you. I'm Wendy Morris. I serve as a Commissioner for the Department of Behavioral Health, Developmental and Intellectual Disabilities.
And Vestina Robbins, Executive Advisor in the department.
And first, we want to just thank you for inviting us here today. We're going to just try to give a really quick overview of what the difference is between a community mental health center and a BHSO.
Please make sure your microphones are on also. It's always,
Okay, can you hear me okay?
yes, we can hear you well.
Okay. All right. First, just a very a brief overview. Community mental health centers were established in 1964 in an effort to assure that a full array of community-based behavioral health services were going to be available to the citizens of all 120 counties here in Kentucky. And that's pursuant to KRS Chapter 210. And again, it provides services for people, for folks with mental health, substance use disorder, as well as developmental and intellectual disabilities. The CMHCs are regional boards, and they are designed to provide services to a designated region. They are all 501(c) private nonprofit organizations, and collectively they do in fact serve all 120 counties. They serve as our public behavioral health safety net and work in collaboration with our 4 state-designated inpatient psychiatric hospitals. Behavioral health service organizations were established in 2014 in an effort to increase the number of providers that could serve Medicaid-eligible individuals. They are for-profit and nonprofit entities. About 70% are for-profit. And unlike the CMHCs, they don't have a designated area. They may choose a county or counties to serve, and we currently have locations in 41 counties here in Kentucky. Okay. Next, who they serve. The CMHCs, the community mental health centers, are required to serve adults with mental illness, including our very vulnerable population of people with serious and persistent mental illness. They're required to serve children with mental illness, including those with severe emotional disability. They're required to serve adults and children with intellectual and developmental disabilities. And they're required to serve adults and children with substance use disorder. It's also noteworthy that they're required to serve everyone regardless of their ability to pay. Behavioral health service organizations, on the other hand, may select one or more services. There's a wide array of outpatient services they can choose from. They may serve adults or children. They may serve those with a mental health disorder or those with co-occurring mental health and co-occurring substance use disorder. And while they could choose to serve folks with serious and persistent mental illness, right now only 5 of the 141 do. They do We have lots of BHSOs providing substance use disorder treatment. We really needed to see more providers in that area, so we're very grateful to have them, and they do great work. So I don't want you to misunderstand my comment on that, but it is a different population. Okay. And so what services? Community mental health centers are statutorily required to provide a full array of services, including inpatient, which again, they collaborate and function with our state-designated hospitals. Full array of outpatient services, partial hospitalization, rehab services, emergency services, consultative and education services, and services for individuals with developmental and intellectual disabilities. Behavioral health service organizations, again, can choose to provide one or more services that are in regulation. They are under no statutory requirement to provide any particular service, and again, it's outpatient only. I do want to, before you go on, I do want to mention crisis, specifically crisis units. I know we get a lot of questions about that. There are currently 19 crisis units in the state of Kentucky. 17 are operated by our community mental health centers, and 2 are operated by Wellspring in Jefferson County, a BHSO that does run those services as well. I know we had a specific question about contracting. We do contract. The department contracts with all 14 community mental health centers. All 14 are subrecipients, and they get general funds along with our block grant funding and other revenue streams, other grants. Those funds are allocated based on formula. So each kind of pot of money for certain services has a different formula. It's based in part on how many people are in that region, the estimated number of people with certain types of illnesses. And then their historical service status. So if they've provided a lot of a particular service in the past, we want to make sure they have ample funding to continue providing that service in the future. Other funds are allocated through a notice of funding opportunity, and all 14 are Medicaid providers. Behavior behavioral health service organizations, we do contract with 5 of the 141. Again, those are the ones that specifically offer services that are for people with serious mental illness or children with serious emotional disorder. We fund one of those for housing, which is specific for the SMI population. Funds to that group are through a notice of funding opportunity, and nearly all, about 95%, are Medicaid providers. I do want to take a couple minutes just to talk about some other requirements. Our department, unlike some other departments in the cabinet like DCBS and Public Health, we don't have local offices. So the CMHCs, for all practical purposes, serve as our local offices throughout the Commonwealth. And they do have a number of what we would call unfunded mandates that might be part of our block grant obligations to the department, which we then pass to the CMHCs. Some might be in statute or regulation, but they're all reflected in their contracts. So first, they're contractually required to provide 24/7 behavioral health service, crisis services. BHSOs don't have to provide crisis services, and in fact, we know several that post the local CMHC crisis number in their office for after hours, because it's just not a service that they provide. They are the operators of the National Suicide Prevention Lifeline. Hopefully you've heard about 988, so that's now 988, and they've been doing that for 15 years. We've been building that system. They're statutorily required to conduct 202A and 645 evaluations for adults and children who need involuntary hospitalization. They again collaborate with our state hospitals to ensure continuity of care, and not just who gets into those hospitals, but to make sure they have aftercare when they get out of the hospitals. They're required to provide assertive community treatment, ACT services, to people who are transitioning from a congregate setting to the community. That's in part due to our settlement agreement with Protection and Advocacy. They are required to provide community-based services to folks with IDD, intellectual and developmental disabilities. They're statutorily required to maintain a telephonic behavioral health jail triage system. They're the primary partners in the implementation of assisted outpatient treatment, AOT, also known as TIMS law. They are required to designate staff to serve as the point person for service members, veterans, and their families. They serve as an official voter registration site. They provide primary prevention services. I could go on, but you get the idea, right? There's a lot of stuff that they do that nobody else is required to do. And that's why when I say they're our safety net and that they really function as our local office, it's because they provide all those services that no one else does. Okay. Next is our map, and I share this map probably in every presentation I give. The different colors represent each of the 14 community mental health centers. And then overlaid, I think it's kind of hard to read, but you'll see there's a number in each one of the counties of how many behavioral health service organizations are in each county. And they are kind of scattered throughout the Commonwealth, again in 41 counties. But if you look closely, you'll see that 40% sit in just Jefferson and Fayette County. If you add the numbers in Kenton and Hardin County, you're going to be up to 52%. So they really are kind of clustered in those areas. And again, the CMHCs are obligated to provide services to everyone in their service area, their region, regardless of their ability to pay. And with that, I will turn it over to Tina to talk to you about CCBHC.
So thank you, Commissioner Morris. In the next 2 slides, I'll provide a status update on the Centers for Medicaid and Medicare's Certified Community Behavioral Health Clinic, or CCBHC, demonstration in which Kentucky is participating. And I know you're already fairly familiar with the CCBHC model, but I'll just briefly recap that it is a new Medicaid provider type. And here on the slide, you'll see what we think are the 3 sort of key elements of CCBHC that distinguish it from other more traditional service delivery models. The first is that certification requires adherence to over 100 discrete criteria that those clinics must meet to be deemed certifiable. CCBHCs must also provide the 9 required services that you see there in the visual, as well as care coordination. And then lastly, a unique feature is the use of an alternative payment model or a prospective payment methodology. On the second slide, you'll see a quick update on our status. So Kentucky is one of 10 states participating in the CMS demonstration. That demonstration is operated through Medicaid in partnership with us. Kentucky's demonstration launched in January of 2022, so we're just barely over 6 months into this, with 4 of our community mental health centers becoming certified as a CCBHC. At this time, CMS has limited the demonstration to these 4 organizations. We're awaiting word on whether we can expand to add more clinics to the demonstration. Medicaid just received notification this morning, in fact, that the Safer Communities Act has extended Kentucky's demonstration period by 4 years, and so it will now run through January of 2028. So we're very excited about that extension. Results from the demonstration will inform Medicaid's decision regarding adoption of the model going forward and whether to incorporate it into the Medicaid state plan. I do also want to mention that to date, 6 of our community mental health centers, including 3 that are participating in the demonstration, have successfully received CCBHC expansion grants from SAMHSA, which allows them to support their readiness for this model. Others have applied recently in the latest funding opportunity that SAMHSA released and are awaiting notification of funding. These grants operate outside of the demonstration, but are in support of CCBHC readiness. So in conclusion, we truly believe the CCBHC model will move our public behavioral health safety net beyond a more traditional service delivery model to one that increases access to high quality care, and through the alternative payment model will offer sufficient flexibility for them to more fully meet the needs of those that they serve.
Thank you very much. And I wanted to make sure that you all came here today because of the topic of the bill that we're going to be discussing, which I'm sure you saw a lot of the controversy during session. When we see all these initials, I often just think, man, it would be easier if we just take this as a type A provider, B and C. We would all probably, okay, we could probably identify that in our heads a little bit easier as legislators when you see all the acronyms. I got a few questions for you just really briefly, just for education for everybody. How are CMHC regions, how are those set? If you can explain how those are currently developed.
So that it is all covered in statute, and I don't know that I can cite that. But the centers that are in place now have been in place for all my memory, and I've been in the field about 30 years. I know there were more at one time, and a couple have merged. But there is any board can come together and make a request to the secretary to be a community mental health center.
Because I was under the impression that there wasn't really a clearly defined thing in statute. That was going to be my next question: is should we define that in statute to define where those regions should be?
Yes, I think we need to define which counties, because again, it's been this way for a long time, and I think that it's pretty ingrained. But in order to protect that moving forward, I think it would be beneficial to have that outlined.
Can an organization be both a CMHC and a BHSO?
Yes, sir.
And so yes, and if they can, do they have to get credentialed separately for reimbursements? In other words, if you're a CMHC and you've got credentialing for that, you decide to become a BHSO, do you have to go through a separate credentialing process to be credentialed for Medicaid, for example?
You do, because the Medicaid reimbursement rate is different for a CMHC and a BHSO for a lot of the reasons I just named.
So they would be paid separately for their services in that regard,
yes,
effectively for that. Okay, so those are some of the kind of the first questions. All right, to our members, we're going to have a few questions. We got a big presentation on this House Bill 349. So, Representative Wilner.
Thank you, Mr. Chairman, and you've covered some of my questions, so thank you. Thank you for the presentation. And Commissioner Morris, do you have concerns about a community mental health center practicing outside of its designated region and calling itself a CMHC when it does so? And can you talk about what impact that has on the whole system of care?
What I can say is this: when a CMHC is outside of their region, they all, for all practical purposes, functioning as a BHSO. They get to choose which counties, they get to choose which service. So they get all of the perks of being a CMHC without any of the obligations of CMHC, which I named. And so it does give them some advantage over every other provider, BHSOs and the other CMHCs in that region.
Thank you very much.
Senator Adams.
Thanks. And you testified that you all supplement with the SAMHSA grant. Can you be more explicit on that SAMHSA grant and where those what was the total amount and where are those dollars going?
for the CCBHC.
Oh, for the CCBHC specifically, or for block grant?
I want to know about, I want to know a total that you all get from SAMHSA and where those dollars go. And if you're not prepared, then I would like you to give it to the committee members.
We can get that for you, yes. Stephanie Crowcraft, my all things financial person, is on her first vacation since 2015, but she can pull that together quickly when she gets back next week.
That'd be
So
great, because
we'll
I know
absolutely
that you're
get to you.
required to spend them on certain,
Yes, ma'am.
on certain line items, and I'm just would like to.
So you're interested in all of the SAMHSA funding, yes?
I would
Our
like to
grants,
see
our
that,
block
yes.
grants, we can do that.
Thank you.
Yes, ma'am.
Representative Riley.
Thank you, Mr. Chairman. My question has been asked. Thank you.
Good. Representative Bentley.
Thank you, Mr. Chairman. And going back to your first question on the statute, the community mental health centers were established by the Federal Community Mental Health Act, which was the last piece of legislation signed by President John F. Kennedy. In KRS 210.3, the legislation established in CMHCs in 1966 created a regional model. So it is by statute that they are regional models. Thank you, Mr. Chairman.
Thank you, Representative. You have 3 more questions. Representative Dodson.
Thank you, Mr. Chair. Commissioner Morris, when there is a crisis in a community, such as the tornadoes that touched down last December, or a crisis at a school, which agency do you contact to make sure mental health services are available to anyone who needs them in that affected community?
It's always the local CMHC that we call upon, and they work with all the other agencies that provide emergency services. So that's part of our state crisis plan.
Okay, thank you.
Chairwoman Mosier.
Thank you, Mr. Chair. Thank you for your presentation. A lot of information here, and I want to go back to the CCBHCs, and I know a little bit about it. I guess I'd like to know the overarching goal. And you talked a little bit about the differences, but what's the overarching goal? Are we looking to follow individuals with SMI or?
And I don't know if you're able to share. There's been some really good success stories because part of it is providing that integrated behavioral health and physical health. And we have had a couple really amazing stories of late at our CCBHCs where they have identified a very serious medical issue that was being dismissed by the medical community as their mental health issue. And so it's really more evidence-based practice, focus on excellence, looking at outcomes, and looking at the whole person as a whole person and not separating out their mental health. So we really do see this as the way to go forward, and we've already seen some really great demonstration of the outcomes we can achieve.
Okay, thank you. I agree that it's a fabulous model, and I know that a lot of folks have been advocating for this for a long time. And can you talk about what the alternative payment model is?
It's a prospective payment system, but I'm going to defer to our Medicaid friends back here because that is
why she's here.
That's why.
Is that okay?
If you could identify yourself for the record, please. And
Yes, sir.
thank you.
My name's Leslie Hoffman. I'm the Deputy Commissioner for the Department for Medicaid Services, and we partner with the Department of Behavioral Health for the CCBHC demonstration. Very exciting demonstration, and I also wanted to mention that it also has an outreach to the veterans, so that was one specific thing that has really come forth with this particular project. The PPS rate that we decided to go with was the PPS-1 rate methodology, which is approved by CMS, and it is a daily per encounter PPS rate. And then we do a cost analysis, and then we do, then we also do a cost reporting, and then we do a wrap payment. So what you may be familiar with is the FQHC, PPS, and wrap. It's very similar to that process. That process may be changed in the future, but that's one we're going with the demonstration right now.
Okay, all right, thank you.
All right, Representative Wilner.
Thank you for your indulgence. I have just a really quick request. You mentioned unfunded mandates, and I wonder if we could get a list of what those unfunded mandates are and how much funding it would take to accomplish them.
Okay.
Thank you.
Thank you.
Senator Berg, very briefly, because we got to get to the next bill here.
I understand, Mr. Chairman. That encounter rate, can you tell me what the dollar figure is?
Each individual has a different, so I don't have that with me today. Each individual's is a different rate based on their cost report and projections.
Percentage of actual cost? Can you tell me that? Is it based on a percentage?
It's based
I'm trying to figure out what the providers are getting reimbursed.
I don't have that with me today, but I can provide that.
Thank you.
That is the eternal question, Senator Berg, is what the providers are getting reimbursed. Yes, absolutely. Ladies, thank you very much for your presentation. I know we're going to jump into the next item on the agenda. This is a good preface to hear the Cabinet's perspective on kind of a definition of what these organizations are. This past year, we had House Bill 349 that was proposed, came out of the House, came to the Senate, and I think a lot of us in the Senate heard, I got more emails about this bill, I think, than any other bill. People on both sides who were for it and against it. There was a lot of things moving very quickly at the end of last session. We just didn't have the time really to dive into this, so we thought we'd take the opportunity to come into the interim and have a discussion on this bill. And so I think first on the agenda, we've got Eric Embry, who's the Chief Executive Officer of Pennyroyal Community Mental Health Center, who I think is on remotely. Eric, I don't know if you're there.
I am.
Very good. And we've also got with us Jennifer Willis, who's the CEO of Pathways Community Mental Health Center, and also Pramod Bishnoi, the CEO of Mountain Comp Care here today, who are going to speak on both sides of this topic. And I thought it would be great for everyone to come in and I told everybody you've got 10 minutes, or basically try to get 20 minutes total here for each side, 10 minutes to present what you liked about House Bill 349, what you didn't like about it, why you thought it was necessary, why you thought it wasn't necessary, and to come in and present for that. And I think everybody should have before them House Bill 349 from this past session and their presentations as well, if people want to refresh their memories about it. Mr. Embry, if you want to begin, if you want to introduce yourself for the record and begin your testimony.
Sure. Jennifer Willis and I are going to tag team this. So, Jennifer, you want to go ahead and get started with the introduction?
Sure. I'm Jennifer Willis. I'm the CEO of Pathways. I'm from a community mental health center in northeastern Kentucky. And I'd like to take this opportunity to thank the committee co-chairs and members for giving us the opportunity to speak about House Bill 349. Obviously, you all heard this last session. We've already talked about that, but we're here really to talk about why we feel like it's critical to us as representatives of the 12 community mental health centers that support this bill, as well as why we feel like it's needed to maintain the safety net for our behavioral health centers. I work closely with Representative Bentley prior to last session working on this bill, and we just want to be sure that we're providing the correct information about the bill, its effects, and how CMHC's operating outside their catchment area really puts the whole safety net at risk. With that being said, I would also like to just recognize that obviously Eric and I are speaking for 12 CEOs today, and I would like for the CEOs and the staff from the community mental health centers that are here in support of that to raise their hand or stand if they feel so moved, so that you can see that support.
All right. I'm Eric Embry. I'm the current COO of Life Skills, a CMHC based in Bowling Green, Kentucky, former CEO of Pennyroyal Center, a CMHC based in Hopkinsville, that merged with Life Skills in January of 2020 for administrative efficiencies while maintaining services in our respective regions. I'm also serving as the interim facility director at Western State Hospital in Hopkinsville at this time. I want to thank Co-Chair Alvarado for meeting us last month at Covington, listening to the importance of 349, for his invitation to come and testify today. Also wanted to thank Co-Chair Mosier, who heard 349 in her committee last session where it passed with no opposing votes. Following passage out of her committee, it went on to the House floor, garnering 75 votes of support. I also want to say that I appreciate the flexibility in being able to testify remotely. If you heard me normally, you can tell that I'm dealing with COVID-19 currently, and my voice is a little off, so I apologize for that. I was going to start off with a couple of paragraphs of what a CMHC is. I thought that was extremely important to start, but listening to Commissioner Morris's testimony, I'm only going to emphasize a couple of points from that. If you were to go to the department's website and read the definition of a CMHC, it would talk about the populations we serve in that 100-word description approximately 4 times, being we serve the mental health substance use, and developmental and intellectual disabilities. It also emphasizes the catchment areas we serve and uses the term regions 6 times within that definition. Also wanted to emphasize the difference between a CMHC and a BHSO is that we are required to have board members in every county that we serve. But going beyond what the commissioner talked about in the definition on the website, our scope of services are so much more. And I'll talk about what we've been dealing with over the past 3 years. When a bomb detonated in downtown Nashville on Christmas Day of 2019, it was Penn Rural Center that was communicating and working with first responders to ensure that all of those individuals dealing with severe mental illness in our catchment area were safe, secure, and getting the treatment that they needed. In 2020, there was a significant outbreak of COVID at Western State Hospital, and we were informed by the department and Commissioner Morris on a Friday evening that admissions to that hospital were to cease immediately. We were to begin working with the department to divert admissions to other psychiatric hospitals. Right after ending that call with Commissioner Morris, the 4 CMHCs served by Western State Hospital, that's 4 Rivers, Penn Rural Center, River Valley, and Life Skills, implemented procedures that allowed us to basically hold the line with 0 admissions to Western State Hospital over the next 6 weeks, while still assuring the patients were appropriately cared for. And in my opinion, that was a truly Herculean feat. When tornadoes struck out in Western Kentucky in the late hours of December 10th of 2021, Commissioner Morris contacted Steve Shannon with CARP, the organization that represents 11 of the 14 CMHC regions, asking whether the CMHCs in the impacted area were ready to respond to the disaster. Mr. Shannon could confidently answer that he would check, but he was sure that we were already responding, and we were. While that phone call was occurring, Penn Rural regional leadership and staff were at Baptist Health Madisonville, assisting those that had lost loved ones and property. We had others at sites like Dawson Springs already involved in the cleanup efforts and assessing individuals dealing with the mental health trauma of such events. We don't wait to assist our communities. We leap into action when needed.
Right. So how are we different? Obviously, Commissioner Morris have spoke to this already, but it is important to just talk a little bit about, we are the safety net providers. We are required to provide all these services. This is why community mental health centers have a different pay scale than a behavioral health service organization. When community mental health centers are working outside of their regions, they are essentially working as a behavioral health service organization. They're choosing the services they provide so they can cherry pick services that have the larger profit margin and just be able to focus on those services while not having to provide the services that we know we lose money providing. And that's worked. It's worked for community mental health centers to be able to provide that array of services because our rates have allowed us, we make a little more money on one service and we lose on another to allow us to be able to cover all of our operations across all of both mental health addictions and with folks with developmental and intellectual disabilities. The other thing that's important to note, and it was talked about quite a bit, was crisis services. And yes, we are, each of us are the crisis, 24-hour crisis provider in each of our regions. But when you have a community mental health center who says they're a community mental health center operating outside of their region and their staff drop clients off at our crisis units without any forewarning, find out that there's not a bed available, and leave them anyway and tell staff that they're not the crisis provider for that region. That's the local, and regional community mental health's problem. They're operating as a BHSO. They're not operating as a CMHC. All of us have experienced this across the region. Our crisis services are very much used by BHSOs, and that's how we're designed. But we have a bigger issue with the community mental health center that's operating out of region, bringing clients and more or less dumping them on us and leaving them for us to take care of. Since this is the case, why should they be reimbursed as a CMHC? It's not fair to CMHCs, and it's certainly not fair to BHSOs. So, it's not fair to the citizens and the families of Kentucky. They deserve more. I mean, our clients deserve better. Nobody should be dropped at a crisis unit and left when no one's there, when we don't have a bed available. Obviously, we took them, made sure they got placement. We did the work. But again, this is not how a community mental health center operates as far as leaving folks. We're the safety net. We make sure that folks do not get left. So currently, we have 27 counties that have a community mental health center outside of their region functioning in the local, the local CMHC's area. 27 counties that are already served and supported by their designated CMHC. 8 of our community mental health centers encountering this threat to maintaining their safety net. So why should you care? Why does anybody care? Everybody says all we need more providers. We need more providers. There is plenty of people in need of services. There's no doubt about that. Kentucky's community mental health centers have historically served a very important function as training sites for a full range of mental health professionals and paraprofessionals. Much of Kentucky's current mental health workforce benefited from training and supervision provided by community mental health centers while they were obtaining their advanced degrees. Because of the manpower needs and the training and supervision structures, community mental health centers are authorized to hire individuals with a bachelor's degree in mental health or human services who are working on an appropriate master's degree towards their advanced degree, providing very specific support and intervention services under close supervision. Care should be taken to distinguish between bachelor-level individuals in training and licensed clinicians or therapists who have a minimum of a master's degree, do not require supervision, and are credentialed by a state licensing board. We are concerned that Mountain Comprehensive Care is using bachelor-level staff, not all of whom would even qualify to be what's called a mental health associate, and telling parents and school personnel that they are therapists when they are not. Would you take your child to treatment to someone who proclaims they're a doctor but only has an undergraduate degree? Of course you wouldn't. This isn't fair to our families, and it isn't fair to our children. Mental health associates who are therapists that's not even a possibility. Mental health associates are not therapists. You have to have a master's level education, be licensed and credentialed to be called a therapist. In addition to that, with House Bill 349, we can and will continue to serve the clients in our respective regions, along with the BHSOs across the state. House Bill 349 simply requires CMHCs who operate outside of their designated and contracted region to provide services under the correct licensure status as a BHSO. The largest community mental health center in Kentucky, 7 county services, based in Louisville, already does this now and does it successfully. We're simply asking that others follow their stellar example and play by the correct set of rules and appropriate licensure. House Bill 349 levels the playing field by putting into statute the regions long recognized in regulation and contracts by the Cabinet and the Department. 349 requires all CMHCs who wish to provide services outside their established recognized region to do so as a licensed BHSO. We know that the licensing isn't expensive. $750 for your first, $500 for each renewal period, and $250 for each extension location. The last of mine.
I would say you're at 11 minutes now.
Okay.
So if you want to just go ahead and wrap it up
Sure.
really quickly. Sure.
I just wanted to say, we are similar in fashion to other quasi-government entities that have their regions defined in either regulation or statute. Child advocacy centers, domestic violence shelters, and rape crisis centers all have defined catchment areas, as do area development districts, school districts, and health departments, also recognized in this manner. CMHCs perform services just as vital and feel strongly that the state's safety net or operational catchment area should be formally recognized.
Ms. Willis, thank you very much. Appreciate your testimony. I'm going to have the folks from Mountain Comp come and present, and then afterwards going to have questions for both sides on this, I'm sure, if Mr. Bishnoy is here. And if you'd like to introduce yourself for the record, please. And again, I'm going to give you 10 minutes if you're going to begin your testimony.
I'm Pramod Bishnoy. I'm the CEO of Mountain Comprehensive Care Center. Mountain Comprehensive Care Center is a nonprofit organization with headquarters in Prestonsburg. We are licensed as a community mental health center, federally qualified health center, and we also have private child caring and child placing license. We are CARF accredited. We just received our CARF accreditation, the latest accreditation in May of this year, and we received the 3-year accreditation, which is the maximum you can receive. We did not have any deficiencies, and all our sites are appropriately licensed by various agencies. So in 2011 with Medicaid managed care, and in 2014 with the implementation of Affordable Care Act, behavioral health services evolved with the expanded types of services and providers eligible for reimbursement.
Mr. Bishno, if you want to pull your microphone a little bit closer, it might
Okay.
be more helpful to be able to hear you better.
All right, sorry.
Yeah, no problem.
So currently, Mountain provides services in 60 counties, and our goal is to provide the best possible care, helping our clients identify opportunities for improvement in their lives. We have been able to create over 1,000 new jobs in our communities, and we have embraced partnerships with homeless shelters, domestic violence shelters, and other organizations to provide much needed services to the most vulnerable. We have three out of 4 Kentuckians live in an area with mental health care shortage, with more than 2,500 of those individuals receiving services from us. We have 38 outpatient behavioral health clinics, 12 primary care clinics, 7 residential addiction treatment facilities. So our staff have increased from 275 to over 1,300. Our individuals served increased from 8,000 to 33,000, and our outpatient clinics increased from 5 to 38. And each, like everybody has said before, each community mental health center has a safety net contract with the Department of Behavioral Health and DBH-DID. Even with this change, we are all CMHCs who are providing services to the individuals that we serve. Kentucky needs more access to behavioral health services, not less. With the pandemic and its lingering effect, the need today is even greater than when the behavioral health network was opened. So some have claimed that Mountain cherry-picks services by partnering with local groups outside their safety net region. Mountain has been invited into those regions by the local groups. When a domestic violence shelter reaches out to Mountain because their local CMHC has a 6-month waiting list, what should we do? If a judge trying to run an effective drug treatment court reaches out to Mountain because of a 6 to 10 week delay in getting people into substance abuse disorder treatment, what should we do? When a homeless shelter reaches out to Mountain because their local CMHC has not provided services to the homeless in over 5 years, what should Mountain do? Mountain chose to respond to meet the unmet needs of our communities. And even in the latest Medicaid manual, it does say that a community mental health center can go outside their 1960s region. So I want to read real quickly for a letter that was written in 2016 by the General Counsel of the Health and Human Services. And it says that the CMHCs are licensed by KRS 210, but it goes on to say that at this time, however, the statute and the regulations do not preclude CMHCs from providing additional services or allow the Cabinet to prohibit them from doing so as long as they conform with the defined administrative and funding obligations. And it goes on to say that requiring a CMHC to get a separate license as a BHSO, a Behavioral Health Service Organization, would only seem to be duplicative, serve to increase their cost, and create additional administrative burdens. So you have also heard that it's just a matter of getting a license. Well, it's not that, because and it's not 500 or 750. If we get an additional license as a BHSO, we will have to get a separate electronic medical record, which could be upwards of over $2 million. We would have to get a separate accounting, payroll, billing software. Those could be additional $1 million, $2 million. We would have to negotiate contracts with managed care companies. So we have 5 right now, and we would have 5 additional ones. And so what if a psychiatrist is in Pikeville one day and in, say, Moorhead the other? We would have to bill those two services under two separate licenses for the same service that is being provided. And so if the psychiatrist is in Pikeville, in our 1960 region, and a person who is their client in Moorhead has a crisis that day, and they see them by telehealth, we would then bill all the services in Pikeville except that one under the CMHC. Providers outside the state can provide telehealth services, but the bill would restrict us from going across county lines, which does not make sense. So changing laws to throw up barriers for CMHCs to provide their services means more waiting list in other areas. Individuals seeking mental health and addiction treatment will find themselves on waiting lists after reaching out for help. Judges would get frustrated for lack of local services with 6 to 10 week waiting period for drug court participant. Homeless and survivors of domestic violence will not get services or get delayed services. Other providers aren't restricted to certain areas when it comes to Medicaid funded services. Even managed care companies are not limited to certain areas. And in summary, I think I would just say that Kentucky should not look backwards. We need to look forward to allow innovation to happen, let providers reach out and try to address unmet needs. Healthcare is heavily regulated with good cause, but that regulation must not be so heavy that old ideas and regions are carved into statute to protect other providers from competition. Even a limited level of competition in healthcare services can reduce cost for consumers and the state and lead to more efficient services. And we have a shortage of healthcare. And earlier it was mentioned that we hire bachelor's level people. Every community mental health center hires bachelor's level folks.
Thank you very much. So a lot of discussions on this, and I was just commenting here with the chairwoman during session how this the comments we're hearing on both sides were things that we heard from emails from people even in our districts, from a lot of providers from throughout the state as well. So the one thing I'll bring up the question that I've heard from both sides, and I'll ask them both to respond to the different questions. Obviously, while you're there, Mr. Bushnell, I'll ask you. Obviously, the commentary is that, okay, you're providing a service for people that are outside. You guys are kind of headquartered in the eastern part of the state, and then you provide services, let's say, in western Kentucky.
Yes.
And then someone that you're providing services for has a crisis or an after-hours emergency of some sort. The other side is saying, hey, we're the ones who are getting stuck with having to provide services with someone that we don't know. You all are the ones who are contracted to take care of this person. And as a doctor, I know I've had situations where I may have had a school nurse taking care of a child in school. They prescribed a medication or treatment. They don't take call after hours. There's a complication from that treatment. What happens? Call the pediatrician on call. I'm the one who gets the phone call, and I've got to figure it out. And I'd say, you'd pull your hair out trying to figure out what to do, and the liability is on you. So maybe you could respond to that, because that is the accusation from the other side, is saying these guys aren't taking care of their patients. We're having to do this. We need laws to fix this. That's what this bill ultimately is about. Maybe you could address that issue.
Sure, Senator. So we take care of our clients that we serve. If they go in crisis, they call us. Our 1-800 number, the crisis line number, is on all our brochures, all our forms. It's on our website. Now, the 25,000 or so individuals we serve outside the region, if they call us, we do provide after-hours crisis services. Now, if somebody doesn't call us, obviously we don't provide those services.
All right. And then if Ms. Willis, if you want to come forward, I've got a quick question for you as well. If you guys just want to hang out, because I'm going to have lots of people coming, and I'm sure there'll be members of the committee who will have questions as well. But
can I address what was just said with what would I do? If you were to look at a contract signed between Mountain Comp and the Christian County Board of Education just this month, it's public information. In that contract, it specifically states they recognize that they are, quote, not the state of Kentucky's designated provider in Western Kentucky for emergency or crisis responses. And then underneath that, every CMHC in Western Kentucky, that's Four Rivers, Funeral Center, Life Skills, and River Valley, our crisis response number is on that contract, and Mountain Comps is nowhere to be found. I hope that's helpful.
Well, and that kind of tees up my next question, which obviously for you all, the concern that I heard from folks on this as well was, why would the Christian County Board of Education want to contract with a CMHC in Eastern Kentucky and not with someone locally or close by? And that ultimately becomes a question, because some were saying what we're creating here is effectively a certificate of need. So you're going to say, we're going to restrict you can provide services in an area. We're going to force you to come in contract with a local provider. That's the only option you're going to have. And right now they're choosing to go with someone else far away. So the question becomes, why are they not contracting with you locally?
They do contract with us. And if another entity were to show up, they would contract with them as well. I'm sure with the school system, they will take anything they can get. And please keep in mind, 349 does not restrict Mountain Comp from providing those services. They just have to do it as a BHSO.
It adds a CON layer. So it's kind of the same thing as, well, you can provide a service, but you've got to get a certain, and that was the concern. And I'm just telling you the feedback, and I'm keeping a very open mind to this, but we had a lot of blowback, again, from two different sides on the issue, and I get the arguments on both sides. But I thought it needed to be aired out here, because I heard even members in my own committee were very, very divided on this issue, to the point where the bill may not have even passed out of committee. So I wanted to bring it here before us to let folks kind of discuss it, ask questions, and then also I'm going to, the cabinet is here. I'd like to get the cabinet's feedback on this as well, where they stand on this issue, because we know the previous administration had opened things up. We've got letters here that I think everybody should have here from 2016 about opening this up to allow this to occur. To get the cabinet's feedback on this, we've had this in place for about 5 or 6 years to see what they weigh in. Representative Bentley.
Thank you, Mr. Chairman. Considering that letter of June 6, 2016, the last two sentences I want to read. It says, we encourage CMHCs, as well as private providers, to collaborate on mutually beneficial service provision decisions whenever possible, and remain aware of the successful outcomes that benefit both communities and individuals. I think that's under the rule of law. The rule of law was established by the President of the United States that there be regions, and also the CC of this is only to, she's out here in the group, Secretary Glisson, raise your hand. You're out there someplace, or you just left. Tim Freely and Eric Clark. Did they send this letter on to the cabinet, to the other CMHCs in the state of Kentucky? That's a good question. So I think we ought to go under the rule of law, like the President of the United States told us to be regions. Thank you, Mr. Chairman.
Thank you. Senator Givens.
Mr. Chairman, thank you. And the question you asked Chairman Alvarado at the very end, I don't know that I understood, Mr. Embry, the answer to the question. If you could repeat your question again, Chair Alvarado, specific to the contract that was entered into by Mountain Care and a local school district, your question was, if I've got it correct, why did the school district choose Mountain Care, someone so far removed? And Mr. Embry, maybe you can answer that again, or someone else.
Sure. The school will take, if another organization were to show up to offer services to the student population, the Board of Education's priority, of course, is the mental health well-being of the students that they serve. So we've got a contract with Christian County Board of Education. They employ their own school-based therapists, and they have a contract with Mountain Comp. So I don't know if that answers your question per se, but if another BH provider were to go and approach them and say, do you want more help? I'm pretty sure the school board would not say, no, we don't. They're going to take all the help that they can get.
Right. And I would just like to add to that by saying in each of our school districts, we're in every school district within our 10 counties, and we have multiple providers in each of those school districts, BHSOs, Mountain Comp, as well as Pathways. And I just to echo what Eric said, I mean, our schools are in desperate need. We know that folks need mental health services. So the schools are desperate to bring in everybody they can bring in. To the issue that I talked about, it's difficult for us to recruit staff. That's why we're the training ground for folks. And so with that being said, that's why. I mean, we struggle, all of us across the board, to have enough providers available. So the schools want, as many therapists as they can have there, as many days a week as what you can provide them. So it's not a matter of not having other providers. I mean, I don't think any of us are arguing that it's a problem to have competition from BHSOs or anyone else. I think the problem lies in the licensure and what's in regulation. As far as if you're operating as a BHSO, you should have a license as a BHSO.
Mr. Chairman, briefly, if we could have the cabinet come back to the table, I've got a question for them if that's appropriate.
Certainly. Commissioner Morris, if you'd like to come. And again, I had my earlier question also, is I'd like to get the opinion of the cabinet on this bill as it was pushed forward. But please, Senator Givens.
Mine's along the same line of reasoning, and thank you for your testimony, laying the ground for us to understand the dynamics of what's rather complex, because we've got folks doing the same thing, different licensure, different titles. We as policymakers are in this space trying to strike this balance between immediate need in the school systems and across our communities for mental health. All of the providers, we need all hands on deck.
Yes.
We truly do. Our communities need that coming out of COVID and facing the anxieties of today. At the same time, we need longevity. We need to be able to sustain operations in these communities so that maybe those less desirable, less profitable services are also provided and someone's not cherry picking. So we need advice as policymakers. So as you come to the table, state very clearly for us the cabinet's position is that what as it relates to this question.
Okay. I can tell you my department's position on this. I have discussed with Secretary Freelander, but I mean, it's more appropriate for him to speak on behalf of the cabinet, so I do just want to say that.
So this is a department position and not a cabinet position.
I have spoken to Secretary Freelander, but I cannot speak on his behalf. But I can tell you.
Please.
Okay. So we do believe that CMHCs going outside of the region does pose some level of threat to the behavioral health safety net. If there is no difference seen with reimbursement and how they operate, BHSOs and CMHCs, what possible reason would those other 13 CMHCs have to continue to be licensed as a CMHC, right? So they're distinctly different. They have distinctly different mission, they have distinctly different obligation, and there are a lot of things that we need providers to do for the folks with serious and persistent mental illness, kids with serious emotional disturbances, people with intellectual and developmental disabilities. And again, there are BHSOs who do that, and I hope more will come forward and do that. We welcome the competition. I was at the cabinet in 2014 when BHSOs and multi-specialty groups and new individual providers were allowed to bill Medicaid. It was a beautiful thing. It's been a great thing to see more people to get services and to have more providers. So there are lots of BHSOs doing a lot of great work, but what they do and what they're obligated to do is distinctly different than what the CMHC does. I've worked in behavioral health for the past 30 years, and they provide again, working, for instance, with our state hospitals. You know, people come to us who are really sick, and the CMHCs help screen those folks before they come into the hospital to make sure they meet criteria and that they don't have any other services that they can do, in-home services, same-day services, crisis stabilization units. And then again, now patients always have choice if they have another provider, but the majority of our patients get an appointment with the CMHC when they leave. So they're part of our continuum of care.
So again, the department position is that CMHC should operate solely in the defined regions that they're located in.
Their contract with DBID only covers what they do in their region. There are $0 of funding in their contract with DBID that they can use outside of their counties.
So again, solely in the contracted regions is the department position.
Yes, all of the funds that the Department of Behavioral Health provides the CMHCs can only be spent in their region. What they do outside of the region is they can bill Medicaid for that, which I think is separate from some of the other issues we're talking about. We restrict the spending, our dollars being spent in their region.
Two quick questions, Mr. Chairman, if I could. Thank you. Thanks for the latitude. Do we have concerns about folks that are currently being provided quality services by these CMHCs that are operating outside of their regions? Do we have concerns about those citizens having to change providers, having to change the doctor they're seeing? Any concerns about that non-continuity of care if we move to passage of a piece of legislation that says solely in the region in which you're licensed or funded?
Because they could obtain they could continue to serve as a BHSO outside their region. It's only that CMHC license.
Any concern about his line of rationale for we're adding bureaucracy to something I'm already doing, or is it really not a concern?
I think, as you said, it's a very complicated issue, and I mean, full disclosure, Mott's and I have known each other for long before I came to the cabinet. I worked very closely with him when I was in Eastern Kentucky.
So
pardon me?
You both seem like really good people. So yeah,
we are.
I can tell that.
And Mountain provides exceptional services in their region. I can't speak to the services outside their region. What you've heard today, I don't have any firsthand knowledge of the quality of services out that region. I do know the services inside the region are excellent, and the people in that community. I think they were recently, got some award for being a good employer or something. But and like I said, there is, because they get a higher rate and they can hire staff with different qualifications, I'm surprised the other BHSOs aren't concerned about that competition, because they have an advantage over other people building that business there.
Last quick thought. Would you press the Secretary to get a cabinet position on this question and get it to this committee?
Yes.
Thank you.
Thank you, Senator. We get 4 more questions, and we're going to have to, because we could talk about this for another hour. I know. Yeah. We'll see, Commissioner. I'll see if other people have questions for you, but we'll call people as we need to. Senator Carroll.
Thank you, Mr. Chairman. And, there's so many different balances to be had here. And, Commissioner, this question is probably going to be for you. I apologize. I heard in the testimony that apparently 7 counties is doing the same thing as Mountain Comprehensive, but they are doing it correctly. And is that the case? And if you're not the person to answer that, please.
It is my understanding that they are also licensed as a BHSO, so they provide services within their region as a CMHC. And I don't know, Kara, or if somebody from OIG can answer, or Medicaid. But yeah, that is my understanding. And I also say there are times, not to introduce a new issue here, but there are times when the cabinet wishes to use one CMHC for a particular service in another area for a variety of reasons. And I think that was one of our hiccups with the bill that came last time, was the cabinet needs to maintain its authority to have some flexibility.
Okay.
Because we have had CMHCs who said, we're not going to do that service anymore, and we have to provide the service to draw down our dollars.
Understood. I guess I'm just curious if there are such financial barriers to Mountain being able to conduct this business outside of their region satisfactorily. How can they? Why is it they can't do it if 7 counties can do it? And I'd really like to get that answer to kind of give validity to what the gentleman says about it not being fiscally feasible for him to do that. And Mr. Chairman, I don't know if there's anybody here that can answer that. I'm assuming no one from 7 counties is here.
I don't know if we want to introduce more testimony. It'll be here, like I said, for another hour is the hard part of that. But it's, but they might be, again, these are the questions that need to be answered ultimately as we move forward. Senator Berg, I know you have a question.
Thank you, Mr. Chairman. My question basically is 2 parts. Do we feel as a state that the CMHCs are currently able to meet the needs of their counties? Or are we talking about 10, 12, 15, 18-week delays in care?
I can't speak to that specifically, but I do know all providers, and not just in behavioral health, are really struggling right now with workforce issues. Until very recently, I would have told you we were grossly underfunded in behavioral health. It's been a longstanding issue, but we've gotten a lot of additional dollars from the federal government and a really nice allocation during the last legislative session, and so we're hoping to move that needle. Unfortunately, we're up against this unprecedented workforce issue, which we're struggling with. But Yeah, I'm sure there are waiting lists in some areas for some services. I know it's hard to get to the dentist right now for myself. They called to cancel because the hygienist called in and I can't get in for 6 more months. That literally just happened to our family. So yes, I'm sure the BHSOs, the CMHCs, our hospitals, we all struggle with some of those issues which might be causing waits.
I think my question goes to did Mountain Health find a need that wasn't being met by the state and is trying to fill that need for us at a profit, of course? Or are they taking away from work that the state was already being able to provide at a more, I don't know if you want to say cost effective, but on a broader scale? And I guess that's my question. Are we seeing basically a problem between what we're able to provide to our citizens by the state versus what we're able to provide to our citizens through a for-profit model?
I think I'm struggling to answer your question because when Mountain is in their CMHC region, they are the state. I mean, they're quasi-governmental, so what they do in their region is on our behalf. And so I guess I'm not sure how to answer your question, but I think we've already heard testimony that there's a huge need. We welcome the competition. This isn't about we want nobody but CMHCs. That's absolutely not what anybody is testifying to. We need CMHCs to be protected so that we can provide services to populations, quite frankly, nobody else wants to serve, including dentists, right? People with intellectual and developmental disabilities, people who have paranoid schizophrenia and have explosive, behaviors at times when they're not getting their medication. People who are acutely suicidal. So we have to make sure somebody is obligated to provide those services because, quite frankly, there aren't very many, 5 BHSOs who are willing to do that. And to my understanding, and I could be wrong, Mats can correct me, I don't think that's the population he's serving outside. School-based services is not taking care of, the SMI and the IDD population.
Very good. Representative Moser, you may have a brief comment on this line
Yes.
of questioning here.
Yes. Thank you, Mr. Chair. Thank you, Commissioner. Just as a point of clarification, when we worked through some of these questions during session, we did talk about whether or not there were unmet needs outside of regions and really talked about the fact that the state funds the regions.
Yes.
And if there is an unmet need that is established, that it could be met, but we kind of negotiated some language in the bill that says if there's an unmet need outside of the region, which the state is funding,
Yes.
that the agency should be a BHSO, and that there should be some sort of approval or discussion within the cabinet so that we ensure that those needs are being met, but that the state isn't responsible ultimately for paying for all of those. Does that?
Yes, and I appreciate you reminding me of some of those conversations, Representative. I think that what the cabinet would prefer to do is that there is an ability in that bill for CMHCs to work collaboratively. So
Yes.
somebody approaches another CMHC and says, we'd like you to come work with our court, with the school, that there's some conversation between the two CMHCs and that's all done kind of everybody knows it's happening. And so I think maybe very early on there was some of that conversation, but.
Mm-hmm. Yeah, we did try to have those conversations. It would ultimately, I think, be positive for the state if the CHMCs work together and we didn't set up some sort of separate CON. I mean, that's not what we want to do. But, I think that there are some projects that are going on within the cabinet, the EHR project, which we funded. I think that would better inform us in terms of data and maybe what the needs are. And I mean, that's maybe a longer term goal, but I think for now, this is the language that we kind of negotiated in making sure that both sides were heard and that the needs were being met.
Yes, ultimately,
Okay.
I think that's everyone's
Yeah.
interest. Yes, ma'am.
Senator Meredith.
Thank you, Mr. Chair. I don't have a question, just a comment. It goes back to the discussion earlier about safety net. And we seem to have lost the focus of that. And it does have the semblance of certificate of need. But when certificate of need was started, it was a cost containment measure. It really wasn't a safety net measure. But I think it has evolved into that. And I just want to be very careful where we're proceeding with this, because each community needs are entirely different. And if you get a mandate from the state that possibly it doesn't fit the situation for a particular community, and it compromises the safety net. So I think there's a real fine balance between providing that safety net, but also providing protectionism to the point that they're not meeting the needs of their community. So how do you balance those sort of things? And personally, I think that's got to be at the community level, not at the state level. Christian County is a good example. I have no idea about their situation, but obviously they have an unmet need. They've made that decision, but theoretically, we could have a process in place where they couldn't make that decision. So I'm not sure we're heading down the right path at all, and that's neither in support or opposition to this particular bill. But I think if the focus is going to be safety net in adequately providing services, we need to be thinking outside the box a little bit. I don't think this is going to address this particular situation, nor any of the other. My background is hospitals. And at one point in time, it used to be the focal point for all healthcare services in the community. But as certificate of need has been eroded, that safety net is also eroded. And now we're at the point that the hospitals don't know if they can survive or not. But again, I don't think that should be a decision that's mandated by federal government or the state. I think it should be community specific, and we need to get involvement more at the community level. Yeah. Again, using the Christian County situation as an example. Is that a good thing or bad thing? We don't know, because that's not our situation.
So I would say that I first and foremost am an advocate for the people we serve, right? So I don't think I would ever advocate that there only be one provider. People should always have choice, and things like school systems and courts should always have choice about who they go to for a provider. So we want as many providers obviously as we can get. Some of the prescriptive language in our contract with the CMHCs though comes from the federal, for our block grants. There are very specific things we have to assure being provided in our state to draw down those dollars. We get audited. We went through that whole process just a few weeks ago. We did very well on that audit, but they look at every dollar, what it was spent on, who it went to, was it appropriate, did we meet did we check all the boxes on our application, and those types of things. But that again, and I think Mr. Embry spoke to this, that's why every CMHC is a regional board with representatives from every county for just that purpose, to make sure that the counties have a voice in what services are being provided, what services are we going to grow, what do we need to just tick that box to meet, and what things does our county need more of? And they do things that aren't in that contract, right? There's other things they can do. A lot of community mental health centers provide services outside of that contract as well.
Well, I appreciate that, but I've never been a big fan of regionalization, because I think the most vulnerable get lost in that equation. And usually the big fish eats the smaller fish, and you end up not meeting the needs of a particular community. I think it really needs to be at the county level. So again, that's what I caution us to do going forward. If we're looking for solutions, saying it needs to be at the local level, if at all possible. But thank you, Mr. Chair.
Thank you. Representative Bray.
Thank you, Mr. Chairman. Question for the Ms. Morris as well. If they're, in the example of Mountain Comp outside their region, kind of in Western Kentucky, if they've got a patient who goes into crisis and becomes a danger to themselves or others, and the 202A process kind of has to kick in, who's responsible for handling that? Is it the CHMC, the local CHMC, or would it be Mountain?
It would be the local CMHC. I don't think there's, I suppose they could do it. The KRS, it obligates a CMHC, qualified mental health professional from a CMHC, do that evaluation. But I don't believe those are being done by anybody but the local CMHC at this point.
All right, thank you.
Thank you. And the last question, Representative Tate.
Thank you, Mr. Chairman, and my question is for Mr. Bishnoi. Sir, can you please describe your board composition, including the board representation that you have in each county that you...
Our board members are from the 5 counties in the Big Sandy Area Development District region.
So you have representation from each county that you serve?
Yes, we do.
Okay.
Yeah.
All right. Thank you. Thank you, Mr. Chairman.
Thank you very much. Again, this is something we could keep talking for another hour. So we've got other topics on the agenda, and this is what we needed to be able to air out a little bit. So I appreciate the Commissioner, Mr. Bishnoy, Ms. Willis, Mr. Embry. Thank you all for coming today. I'm sure this is not the last of this topic we're going to be hearing about. I suspect we'll be revisiting this up again in the upcoming session. I thought we needed to just have the opportunity to air this out. And I appreciate everybody's input, really, and a lot of the thoughtful questions, and I'm sure we have more to discuss or maybe even more to negotiate on this to see if we can come to something if we're going to be moving a bill forward. So thank you all so much for your presentations. I appreciate that. We've got a few more presenters. I'm going to have the next topic I'm going to bring up is something that I'm sure will draw a few more questions from members of the committee as well, so I'm going to have them come up next. It's going to be regarding House Bill 569, Consumer Protections Relating to Kratom. And Representative Callaway had presented this bill, and hopefully he is here. And we've also got, I believe, Mac Haddow, who's a senior fellow from the American Kratom Association. Also, there's a couple folks, I think one person in person, Dr. Lindsay Blair, and then also Dr. Jack Henningfield, who's remotely with us. And then I've also got the Chief Executive Officer of New Day Recovery Center, Dr. Alan Schultz, who's also going to be testifying remotely regarding this topic. Kratom is a topic I think a lot of us have heard about. People may not know. I know the House kind of had a hearing, I think, on this during session and had it, but I don't think our Senate members have had an opportunity to discuss it. Representative Callaway, if you'd like to take a few moments, if you'd like to introduce yourself, your guests, and begin your testimony.
Yes, sir. Thank you, Senator Alvarado. We appreciate the opportunity to be able to present to the committee today. I am Representative Josh Callaway out of the 10th District, and we did carry House Bill 569 last year in the House and had a lot of discussion about this particular subject of called Kratom. Some people know it as Kratom, but you take your pick which one you want to call it. It is definitely something that I've learned a lot about over the last year. I won't take much time. I'd like to get some of our guests that are very knowledgeable about this subject to be able to give you as much information as we can get in today. The bill that I carried last year was simply based upon safety for this particular product that is already currently being sold in our state. And House Bill 569 did some simple things but important things, created an age limit for this particular product. It stopped adulteration of the product and contamination, which we found out through the studies that we did that was a lot of the issues that we were having throughout the country. It limits extraction levels as well, requires proper labeling, and also created fines for people that violated those guidelines that we put in place and guardrails. At this point, the DA and the FDA have not taken a position on this particular product, which is why I felt it important that we do something and do something immediately so that we could make sure that we protected the consumer and also protected our youth who have access many times to this particular substance. So with that being said, I will turn it over to Mac Haddow, who has also joined us remotely, and let him talk a little bit and introduce the other people that will be talking and give you as much information as we can, as quick as we can. Thank you.
Thank you. If you'd like to
thank you, Representative Kidd.
Just introduce yourself for the record, please. Thank you.
Yes, my name is Mac Haddow, Senior Fellow in Public Policy with the American Kratom Association. And Chair Alvarado and Chair Moser and members of the committee, thank you for this opportunity to talk about Kratom today. About a year ago, we planned a family vacation to Disneyland for our 11 grandchildren, and that's where I am today. My wife and I are planning on celebrating our 45th wedding anniversary, and I'd like to make it to 46, so that might account for my decision not being with you today, and I hope you understand. With respect to Kratom, Kratom was first introduced to the United States. It grows ubiquitously in Southeast Asia when our soldiers from Vietnam came home, and they had found it to be a very popular item over in Vietnam where they could get through the hot days in the jungle by plucking the leaves of the kratom plant, chewing on them, gave them increased energy and focus, and got them through those hard days. And so they self-imported it back to the United States after they came home. We also had a very substantial increase in the Hmong population to the United States about the same time period. And the Hmong group has used kratom in their diet for centuries. And so there were mom and pop delis that popped up around the country. And all of that fast forwarded until about 2009, when there was a report of 9 deaths in Sweden attributed to a powdered kratom product known as Krypton. That got the attention appropriately of every public health official in the world, including the FDA. And so in 2012, the FDA implemented an import alert, and they began the process of evaluating as best they could the available science on Kratom. And that led in 2016 to their recommendation to the Drug Enforcement Administration that Kratom be scheduled as a Schedule I substance under the Controlled Substances Act, meeting the 8 factors that are required by the CSA at the federal level, which are mirrored in large part by each of the states. The Drug Enforcement Administration, in an unprecedented action after reviewing the outcry from the Kratom community and scientists and consumers, withdrew that recommendation, had never done so in the past, 82 previous times of these kinds of recommendations. They asked the FDA to provide what's known as a full 8-factor analysis, is a complete scientific dossier, which the FDA did about a year later. That recommendation was formally withdrawn by Assistant Secretary for Health, Brett Chouat, in the Trump administration on August 16th of 2018, in what many attribute to be or characterized as a scathing letter, claiming that the science that was provided underpinning this recommendation was disappointingly poor evidence and data. And so to this day, there's not been any action taken by the Drug Enforcement Administration in order to proceed with that scheduling. The FDA did, in 2021, petition to the international community and the UN Commission on Narcotic Drugs, of which the United States is a partner, a treaty partner, and they asked for the international scheduling of Kratom and provided the full and complete scientific dossier that they have available. And after a complete comprehensive review by the Committee on Drug Dependence at the World Health Organization, they recommended that there was not sufficient evidence to justify even international scheduling, which has a much lower bar for scheduling. That led in this year, Secretary Becerra issuing a letter with regard to Kratom, indicating that there were significant knowledge gaps about Kratom and there would not be a pursuit of scheduling of Kratom going forward. So where that leaves us, and he acknowledged, by the way, that much of the safety data that had been provided by the FDA and relied upon by many people in good faith was inaccurate and inappropriate, given that the deaths or the adverse events were actually caused by polydrug use or adulterated Kratom products, or in some cases, contaminated products. So there wasn't a justification under the science and the criteria of the Controlled Substances Act for scheduling. So today, Kratom is legal in all but 6 states that enacted bans between 2019 and 2009 and 2017 at the behest of the FDA, none since. And since that time, 7 states have passed the Kratom Consumer Protection Act, which is the framework outlined by Representative Callaway, which ensures that a consumer, in this case in Kentucky, would go into a retail establishment and purchase a Kratom product and would be relatively certain that it was non-contaminated, not adulterated, and safe for consumption. And we think that's the most important thing because we represent consumers, not the vendors. We advocate for the products that are sold in the states to be done in a way that is appropriate, highly regulated, and that it is safe for consumption. And that's what we're doing. In the state of Ohio, which we hope will be the 8th state to pass, it passed 82 to 10 in the House. It's now before the Senate, and they'll take it up this fall. And there are a number of other states in the same situation, including Pennsylvania and New Jersey and Michigan and Wisconsin and some others. So the progress of the understanding of the science of Kratom has gone forward directly, all with the support of the National Institutes of Drug Abuse. They are funding more than $30 million in studies on Kratom. It is with the support of the Department of Health and Human Services that is working on human clinical trials on Kratom. The U.S. Congress for the past 4 years has passed report language in the budget appropriations bill calling not to ban Kratom, but to allow it to be accessible for people, particularly because of the evidence that's being presented now that people are able to use Kratom in a beneficial way as a harm reduction tool to get off of very dangerous opioids. And there's a Johns Hopkins study that documents that. Dr. Henningfield, who I don't think is on right now, and if he's not, I'm sure he'll submit his written record for you, can give you the details on that research because it is phenomenal when you look at it. We work with the addiction recovery community because we know that despite Kratom not being dangerously addictive under the criteria that's established by the Controlled Substances Act, you can become dependent on Kratom. It requires responsible use, and that is key to the labeling that we think the states should require. So from that standpoint, we hope that Kentucky will become a state that joins in this community of those states protecting consumer protections. And I appreciate, again, the opportunity of having had the the opportunity to present here today and stand ready for any questions at the end of the presentation. So thank you.
Thank you. Next, I would like to refer to Ms. Lindsay Blair as an independent researcher that has studied this subject as well and then had some testimony that she'd like to provide today. Thank you. Could you introduce yourself for the record?
It's on. Thank you. My name is Lindsay Blair, and I recently successfully defended and submitted a dissertation to the University of Louisville School of Public Health and Information Sciences, Department of Epidemiology and Population Health. My dissertation, which in part contained analysis on Kratom legislation and subsequent opioid overdose mortality, and I thank you for this opportunity to share the results of this study as it relates to this bill. So when it comes to Kratom, there are opposing views. One common view is that Kratom is a safer alternative for prescription and illicit opioids, and it provides effective pain management, and it's a novel way for people with opioid use disorder to wean off of more dangerous drugs. And then the alternative view is that Kratom itself is a dangerous and addictive opioid, and it may lead users to more dangerous opioids and ultimately higher rates of opioid overdose mortality. So since 2009, 6 states, including Indiana, Vermont, Wisconsin, Arkansas, Alabama, and Rhode Island, have banned Kratom in an effort to mitigate the addictive and dangerous properties of Kratom. So we use an interrupted time series analysis, which is the strongest method for assessing the effects of a broad-based intervention, such as a state-level policy. And we evaluated the effect of these Kratom bans in these states on subsequent opioid overdose mortality. And we used the overdose mortality rates from 2005 to 2020. So in an interrupted time series analysis, a time series of an outcome is used to model an underlying trend, so the pre-intervention trend. And it's interrupted by an intervention at a particular time. And here the intervention is the Kratom ban. So the expected trend that would have occurred in the absence of the intervention serves as the counterfactual to which the impact of the intervention is compared. So before the Kratom ban, we saw opioid overdose mortality rates were significantly increasing in every state except Vermont. So in the analysis, we controlled for this trend, and we found that rates continued to increase significantly in 5 of the 6 states. And I do want to note that there was no observed effect of the Kratom ban in Rhode Island, but Rhode Island was the last state to implement the ban, and there were only 3 points following the ban implementation, and this result may not hold with additional years of opioid overdose mortality data. So we cannot say that definitively that the state-level Kratom bans caused a significant increase in opioid overdose deaths that we saw in this study, but I think it's important to note that banning Kratom did not work to mitigate the opioid crisis in any state where those bans were put into effect. So we did not see rates decrease after the ban was put in effect. On the contrary, we saw significant increases. So currently there are no quality control standards or procedures in regard to Kratom production and distribution. And not only is it being adulterated with illicit substances, but the FDA has issued warnings about high levels of heavy metals in Kratom. And that can potentially lead to heavy metal poisoning or increased risk of certain cancers. And currently in Kentucky, consumers, they can't guarantee that what they're consuming is pure Kratom, which increases the risk of adverse events. So given that Kratom doesn't meet the criteria for scheduling under the factors set forth in the Controlled Substances Act, then the best protection for consumers is to make certain that Kratom is sold in its pure, unadulterated form.
Very good. Is Mr. Haddow, is he available, or is he's on my agenda? I wasn't sure if he was available to testify or.
I'm sorry.
There must have been some glitch. I'm sorry. It's for Dr. Henningfield. So I assume he'll just submit a written statement for the record and be glad to follow up with committee members.
Very good. Very good. I appreciate that. This is obviously a very, Representative Callaway and I've talked about this quite a bit, and I think your original bill was a ban, if I'm not mistaken, to say we're not going to have Kratom in the state. And then after your study and research, you said, well, maybe that might not be the best approach. It's interesting that the federal government decided to make this a scheduled drug and then remove that, which I don't think I've ever heard that in my lifetime of a drug that's been done that. So it still is legal federally, but it kind of leaves us open, and there's a lot of discussion. And I know there's a lot of colleagues who don't like this product. And I work in substance use recovery space, and a lot of people who do not like this. So there is a counter argument to this, and people who support a ban. So I'm going to have Dr. Alan Schultz. I think he's on remotely. Dr. Schultz. There you are, Alan. Very good. If you'd like to come forward, introduce yourself. It's good to see you. And introduce yourself for the record and provide your testimony.
Is this on? Yeah, I'm Dr. Alan Schultz. I own a residential treatment facility, an outpatient facility in Lexington, New Day Recovery. Been in the business since 2003, started treating opiate addiction at that time with a form of Vivitrol that was made in a pharmacy in Chicago. So I've been around a few times. Okay, I am going to say I do not believe that we should address kratom as a toxic substance or a substance that causes damage to the human body. I agree purifying it takes that risk out, and I agree that that a lot of the problems that arose from kratom use that we saw from a medical perspective were caused by impurities. But what I want to be crystal clear about is we're talking about an addictive drug, period, end of sentence. Now, we can call it a natural substance. We can say that indigenous people use it. True for cocaine as well, tobacco, opium. The indigenous people that use kratom generally chew on 3 to 4 leaves during the time they're using it. And these leaves are big, so 3 leaves. But let me explain something to you. The leaf weighs about 10 milligrams. So 1 gram of kratom is probably 100 leaves. And the dose that people take come out to about 800 to 1,000 leaves a day. So we're talking a totally different scenario here than chewing on leaves as an indigenous population. Now, as already mentioned, there are 6 states that control kratom, but there's also countries that control kratom. That would be Thailand, Vietnam, Malaysia, South Korea, Australia, Austria, Poland, Denmark, Lithuania, Sweden, Britain, Israel, and Romania. Now, 3 of those countries is where kratom comes from, and they ban it. So maybe we've got a problem here. The FDA has nothing to do with those countries. Now, we'll talk about prevalence. Kratom started out at 2017, I believe about estimated 5 million people were using it, and it's now up to 16 million. Imports exceed 50 million doses in a year. And if you look into the numbers of people who use kratom, you get different numbers, but one I picked out of a research paper shows that 48% of the people use it for pain, 22% of the people use it for anxiety and PTSD, and 10% use it just to increase their energy level. So let's talk about kratom as far as the substance in it that is, I consider, dangerous. There's 2 substances, metragenine and 7-hydroxymetragenine, or metragenine. It's like kratom, it has different pronunciations. But first off, I want to say that 7-hydroxymetragenine is 16 times more potent than morphine, okay? It directly binds to the opiate receptor, directly. Now, how can you say a medication that binds to the opiate receptor and stimulates it is not addicting? There is no medicine in the world that you can say binds to the opiate receptor and stimulates it does not cause positive reinforcement. And that's what we're seeing here. I see patients every day, and I have talked to many people in the recovery industry and also in drug court. What you see is, number 1, positive reinforcement, meaning that it gives you a euphoric feel and you want to take more of it. Kratom, like most opiates, requires higher and higher doses to get the same effect. So you see people taking higher doses. Then you get negative reinforcement. When you miss your dose, you feel bad, so you take it. When we see people that are trying to get off kratom, they go into withdrawals, okay? Simple as that. They experience cravings, and one study showed that 80 to 89% of people return to kratom use. So it has a high relapse rate. We in the treatment industry consider kratom to be a relapse. It's not unusual that most drug courts, including Fayette County, consider kratom a relapse, and the judge will order additional treatment. We see it as a relapse, plain and simple. Now, the treatment for kratom addiction, this is where it really gets interesting. Suboxone is the treatment for kratom addiction, okay? So it's obviously something that stimulates the opiate receptors, because if Suboxone makes the withdrawal go away, you've got an opiate stimulation. You can also use Vivitrol for kratom. We have had to we have had to add kratom to our drug screens, simply because the problem we see with it. Now, a lot of people say harm reduction. Okay, harm reduction is not a medication in a gas station, okay? That's not harm reduction. Harm reduction is done by professionals with FDA-approved medications that can help people. You can get kratom in a gas station, okay? Mm-hmm. That's not harm reduction. Compared to other opiates, the one thing kratom doesn't do, and it's really good, is it doesn't depress your respiratory drive, okay? Doesn't do that. So overdoses are not going to happen for the most part. I would suspect anybody who's had an overdose that it's not due to kratom, it's due to something else. But that doesn't mean it's not addicting, okay? And we talk about people switching from heroin to kratom as if that's a good thing. And I guess it is. Mm-hmm. But what about the people who start with kratom and end up at heroin? I mean, it goes two ways, guys. This is a gateway drug by definition. It is a gateway drug. You'll see an increase in overdoses. I saw her study. Yes, you do see a slight increase in overdoses. But I want to remind this committee that when we took Oxycontin off the market and we closed down the pain clinics, what did we see? An increase in overdoses. Now, why don't we put Oxycontin back on the market based on that argument? Because overdoses will go down if we go to Oxycontin. I mean, it just seems logical to me to say that the increase in overdoses is not necessarily an argument to keep it on the streets. I just think it's crystal clear, and I've gone over the pharmacology, and maybe you all can ask me some more questions, and I'm open to answering any questions, but please.
Dr. Schultz, thank you. Appreciate that. Like I said, I know this is a topic that I think a lot of us have heard about. And if we go to legislative conferences, you hear states that have done this. There's the American associations come and talk to a lot of legislators. And so I think for a lot of us that we're not around this, we haven't seen it purchased or used, or you don't hear about it, it's kind of a nebulous topic. So this provides everybody, I think, a little bit of a base of what this is. And your arguments are the things I hear from other providers in substance use recovery also who say, this is a problem. This is not a good drug. And there's some who advocate banning it as well. So that's good. I thought we'd have an opportunity to air it out here. I know Representative Bentley, you have a question or comment.
Thank you, Mr. Chairman. I have 2 or 3 questions, and any of you can answer my question. If I was to go to Mayo Clinic and I had severe toxicity from kratom, what would the drug be that they would doctor me with?
Do you mean, if you were addicted to a kratom and trying to come off of it?
I said severe toxicity.
I don't know what severe toxicity you're talking about.
If all the receptor sites are full, the kratom, you said it worked at the opioid receptor site.
Yes.
And I went into the emergency room and I'm in toxicity of kratom. How are you going to treat me?
Naltrexone. Or
what is that called normally?
That's an opiate blocker.
I know, but what's it called by trade name?
Oh, naloxone. I'm losing. I know what you're talking
Narcan.
about. Narcan, yes.
Okay,
yes.
so I want the committee to know that if you had toxicity,
you would take Narcan.
Mayo would treat you with Narcan. So what's that tell you?
Precisely. The fact that Vivitrol works, which is a blocker, tells you that too.
The second question I have for you is, does Vivitrol give you dopamine pleasant effects?
Vivitrol?
Yeah.
Not necessarily, no.
But does it affect the opioid receptor?
Yes, it does.
Well, a minute ago you said that anything affects the opioids. Tell him what he said.
That if it affects the opioid receptor, then it's an opioid.
It's an agonist. I should have said if it's an agonist, an opioid agonist, it causes pleasure.
So you were incorrect in what you said there.
Yeah,
you said there was no drugs that affect the opioid receptor that it can give dopamine euphoria, and
right.
Vivitrol does not.
Right. And Kratom is not the same euphoria as you get from an opioid. And contrary to what Dr. Schultz said, in its pure form, the more Kratom you take, the worse you feel. It's more effective at low doses. In its pure form, not in its adulterated form, which is what we're advocating for.
Same thing could be said about Suboxone. In its pure form, low doses work, high doses make you sick, and Suboxone's controlled. And yes, I did make the mistake of saying it. I should say an agonist. Any
Well, I
opiate
just want the
agonist.
community to know the right answer to that.
Yeah.
There is more. And just the other one.
So, Mr. Chairman, could I just add one additional item here?
Sure.
Dr. Schultz obviously and I disagree strongly on the science, and I would ask you to rely upon the scientific record from the National Institutes on Drug Abuse on the pharmacologic action and the addiction liability of Kratom. They are inconsistent with Dr. Schultz's conclusions, which are understandable given the outdated science that was originally promoted by the FDA. But the truth is the pharmacologic activity of the two alkaloids, metrogynine and 7-hydroxymetrogynine, are partial agonists. That's why they don't go to the respiratory system. They also do not go to the center of the brain that gives you that reinforcing high that drives people back to the addiction. And so that's critical when you look and evaluate this. And this is in the science. We'll be glad to submit these scientific records. I respect the fact that there are concerns in the community, but if any physician were to treat a patient who presents with a Kratom dependency with Narcan or Suboxone, that's not the appropriate treatment for a dependency that is from the caffeine coffee plant, the way you treat a caffeine addiction. It's just not appropriate. It's outdated, and I think the science will prove that. But I'm glad to come to Kentucky, sit down after the Disneyland venture, and I'll sit down with Dr. Schultz and we'll work through this, and I think we could have a good
Well, you'll
discussion
need to. You'll
about
need
how
to
to
work
resolve
through
this.
it because I don't agree with what you're saying.
I still have the floor.
Right. So, Dr. Schultz, I'm
Yeah.
not asking you to agree with me. I'm asking you to look at the science. And then one last point. Thailand, correctly, Dr. Schultz had said, had banned it. But last year, they removed the ban because they looked at the new science. And that's happening in the other countries too. So I think that this is an evolving scientific discussion. But the bottom line is Kratom's legal today. And as Dr. Blair said, you've got to control it in some way to make sure that you're not getting these adulterated Kratom products. And that's what we want to help protect consumers on.
Well, we're not talking about treating Kratom addiction with Narcan. He mentioned toxicity, which would remove it from the opiate receptors. And as far as using Suboxone, it's heavily documented in the literature that Suboxone works for Kratom addiction.
Right, the Representative Bentley.
That's not accurate.
Yeah, it is.
Representative Bentley, any other? No.
You know, relapse was an interesting word used too. The most addicting drug known to man is nicotine.
Yeah.
And we see relapse in it all the time.
Yeah.
So I don't know if that's really a good argument or not. And just a point, you know, when you do go to a gas station and you can buy this free, you can also get gas, and if you got it in your lungs, it could really hurt you. Lipid pneumonia. So consider that toxicity also.
Thank you, Representative Bentley. Next, Senator Berg.
Thank you, Mr. Chairman. I have a quick question that goes back to the original testimony of our a friend on Zoom, where you said that we could be relatively certain that we have a product that is free of contaminants. And, you know, as a physician, relatively certain to me was like not a high enough bar. So my question, if these drugs are primarily illegal in their countries of origin, how do we know that we're getting a product that is free of contaminations and not simply be relatively certain of that?
So thank you for that question. And this is a critical issue. Currently, the manufacturers of Kratom in an unregulated setting do not test for contaminants. Under the Kratom Consumer Protection Act, they would be required to test for all contaminants, and they would reduce them down to the levels required by the FDA. So I gave you the qualified answer. The FDA preaches that you can be relatively safe under the standard for botanical products for contaminants. They simply make the point that you can't eliminate to zero risk, but you certainly wouldn't have a Kratom product that would create a health hazard to the individual patient or consumer if the Consumer Protection Act were in place and the manufacturers are required to produce an independent certificate of analysis documenting that they're compliant with the Kentucky law if it's enacted. And that's what works in other states.
All right, we have one more question and comment on this. Chairwoman Mosier.
Thank you, Mr. Chair, and thank you, everyone, for this discussion. Yes, we did start having this discussion in the session. As a reminder, the original bill was a ban, and the more we talked about this, the more we realized that this is a product that is already in gas stations. It's already out in the markets. And at the very least, while the FDA and NIDA are deciding how to handle this, we thought, at least regulate this to keep it out of the hands of minors and impose some penalties for retailers who were not following the law. Dr. Schultz, if the issue of Kratom is so crystal clear, why, in your opinion, has the FDA and NIDA not made a decision about how to schedule Kratom or not schedule it?
Well, to be honest, I think we're talking 16 million users. We're talking a large market for this substance, a lot of money being made. And I think they are concerned. I think it does worry them that people do increase in overdoses after Kratom is removed. I think that is a worrisome trend, and I do. But I would say that Suboxone is basically a partial agonist, identical to Kratom, if that's the argument, and it's controlled. So there's a lot of concerns about those possibilities, because what we're seeing now is people dying from drugs that are contaminated by fentanyl, and that's not Kratom. I don't mean that. So it is scary to see these type of issues. I think eventually it will be controlled.
So Chair Moser, if I could just add an additional item of consideration by NIDA and the FDA, and that is the science, not the pressure from any advocacy group or group of consumers, but rather the outcome of the science. And we will share with you the scientific research on the addiction liability done by the National Institute on Drug Abuse, where they concluded there was no significant addiction liability, and the new scientific articles that show the harm reduction potential, which is why the director of NIDA is so a great advocate for Kratom. We think those are the kinds of considerations that ought to be done. And the bottom line is that this evolving science, and this is why the Secretary of Health and Human Services today says that Kratom is not a candidate for scheduling based on the current science. And that's the important point that we're making here. If everything that Dr. Schultz says, and I accept in good faith he's doing it honestly, based on his experience and research, if what he was saying were true, this would be a scheduled substance at the federal level. It is not, and not because of any pressure, but because of the science that doesn't document the criteria that's required for scheduling of any substance under the Controlled Substances Act.
I'll make you a deal. If you show me the science, I will come back to this committee and retract what I said.
Very good. And that might be a call for. I'll tell you, what I always prefer more than retrospective analysis is prospective studies. And so if you've got those, I mean, because people can go backward in time and try to read them, but I don't always trust retrospective analysis. I prefer prospective studies to say, we did this, we gave this, here's the outcome, and we geared it, and you have that. To go backwards and try to predict something based on the past and try to read the tea leaves, no pun intended, going backwards on that, I'm not a real big fan of. So that would be something I think would be welcome for the committee.
If I could just wrap up and agree with you, and also I would like to add that science is critically important for the researchers and for the FDA and for NIDA to determine how to handle this, not legislators. I think our job is to protect consumers. Mm-hmm. And in the meantime, I think the very least we can do is to put some regulations around this product to protect the youngest individuals who might be accessing this while the FDA and NIDA makes a decision. I don't like legislators being put in the position of determining whether or not something is a medication or whether or not something should be completely banned. So I just want to add that. I think that this is an important issue, as are other drugs that have come before our committee and our legislature, and I think that the FDA and NIDA ought to take a stand on this.
We have one more question. Senator Carroll.
Thank you, Mr. Chairman. And Representative Callaway, from a law enforcement perspective on this, what would the someone who is under the influence of Kratom, what symptoms or what traits would they exhibit?
So from the studies that have been done, everything that has been determined when someone is under the influence, that those symptoms were able to be easily exhibited, that the product had been adulterated. Same thing with the deaths or the overdose deaths. People had adulterated the product or had been contaminated, but primarily adulterated, and that's the reason why Mr. Haddow can talk a little bit about, to what it does. A lot of people, they say it's a lot like caffeine. It's a lot like those types of substances. It gives you the same type of feeling that you would with that. This is what I want to make clear. I too run a transitional living home. I deal with addicts every day of my life. That's what I do. And I am not at all sitting here advocating for anything in particular, except for that we have a product that has no guardrails on it at all, and it needs them. There's more studies that I want to do. I'm not saying that it doesn't have good uses for lots of things. I've had thousands of people that have literally reached out to me over this particular issue when I filed the ban. But the fact is, right now, we can't ban it because we don't have the support to do so. And we cannot sit here and do nothing because it is so readily available and unregulated. Kids can literally go buy this in gas stations. And so my point has been, let's do something, as Co-Chair Moser said. Let's do something and then see what the FDA does and where they go with it, or whoever might be involved in that, and make that decision. But from a law enforcement standpoint, typically there has been adulteration when it has been a known substance that they were using.
Thank you, Representative Callaway. Thank you all. Again, we could talk about this for a lot longer, and I appreciate your approach on it. And I know that it was actually a clause in the bill that was a trigger, that if the FDA or the DEA made this a scheduled drug, that we would honor that from the DEA. Correct. So I appreciated that part of the bill as well, but thought we needed to have this discussion, and obviously a lot of passion and a lot of providers who have had experience and are concerned about that for patient safety. So thank you all so much for your time. We've got two more presentations. We're just going to hear testimony. I'm not going to have any questions on them, so they can come and present. I promised Representative Fleming he'd come and talk about an important topic for him also, is Safe Kentucky, which is mental health care for first responders. If you'd like to come forward, and I think Dr. Martha Mather and Rachel Lusinski are here as well. Or I guess Ms. Lusinski might be remotely. Is that correct? She's in remotely. But if you'd like to come to the table, introduce yourselves. I've allotted 10 minutes for testimony on this topic. You can introduce yourselves and begin your testimony.
Thank you, Mr. Chairman. This is not about tea leaves or anything along those lines, so hopefully this will be an enlightening discussion. But I really think it's more of maybe a life-saving discussion that we'll have with you. I just want to express my appreciation for coming and testifying before you today. I'm going to go ahead and introduce my guests, Martha, and then I'll have Rachel, who's online. She'll introduce herself as well.
Hi, Martha Mather. I should correct that I'm not a doctor, but I am very enthusiastic about all the mental health talk today. I'm the CEO of U of L Health Peace Hospital in Louisville.
Rachel?
Hi, everyone. Thank you so much for the chance to be here today. My name is Rachel Lusinski, and I'm the Director of Community Crisis Services at the University of Utah Health.
Great. Thank you, Rachel. Thank you, Martha. We're here today basically to present to you all a tool called Safe Kentucky. It's a one-click away app for K through 12 students, teachers, and parents to have 24/7 access that will serve two purposes. The first purpose is to have access to a mental health professional that will provide some life-saving intervention services, and then two, it provide a report for school and safety concerns. Some time ago, I reached out to Utah, and they were very, very helpful and gave me a very very good understanding of what Safe UT, which this product, or so this service is modeled after of. And we had a meeting early January, and Martha was kind enough to attend, and she's been on board ever since. And so she's basically going to be the backbone to get this product up and running. In a nutshell, we're looking at doing a pilot project with some schools. We had a meeting with the Commissioner of the Department of Education today. He's enthusiastically excited about this. We've talked to several school districts. They're really considering by doing this. Once again, it's going to be a pilot project and hopefully have it fully implemented hopefully sometime next year, which I'll introduce a bill and then also some funding mechanism. What I'd like to have Martha to do is give sort of a little details about that, and then have Rachel give what her experiences have been and some of the information she's come across.
Thank you, Representative Fleming, and thank you to the committee for having us today. The Safe KY app is a wonderful opportunity for our communities to offer short-term behavioral health crisis intervention to students, their families, and educators, 24 hours a day, 7 days a week, 365 days a year at no cost to the user. We would have licensed clinicians trained to build quick rapport with individuals using therapeutic interventions. This could be through talk, text, or chat. And as Representative Fleming mentioned, there's also a school safety feature where concerns of potential violence can be reported. And now more than ever, Senator Owens mentioned earlier that following a global pandemic, we need to ensure access to behavioral health care, which this initiative will offer. It's important for everyone, especially our kids, to know that they're not alone and that behavioral health challenges are very, very common. So I've been working closely with Rachel and her team at Safe KY. Utah rolled this out about 7 years ago, and they've had some very successful outcomes. It took them about 7 years to get to the entire state of Utah. So Representative Fleming mentioned that we would want to pilot this in a couple of school districts first. As Rachel mentioned, she is the Director of Community Crisis Intervention and Support Services at the Huntsman Mental Health Institute at the University of Utah. And Rachel, thank you for being here today to share some of the outcomes with the committee.
It's absolutely my pleasure. Like Martha and Representative Fleming have mentioned, Safe UT was born out of legislation in the 2015 general session in Utah, and it was created to address a crisis that was affecting the state of Utah, where suicide is the leading cause of death for youth in our state, ages 10 to 24 years old. We also know that school safety concerns, such as planned school attacks or threats of violence, are closely correlated with underlying mental health challenges or unresolved behavioral health issues. And so what Safe UT provides, and what this model for Kentucky could look like, is 24/7 life-saving access to master's level mental health professionals who can quickly build rapport, de-escalate crisis situations, and have really positive outcomes. What we've seen in Utah, last year we had more than 30,000 chats that were submitted with more than 1 million back and forth message interactions with users. We know that students are always on their smartphones, and so this is a wonderful way to meet youth where they're at, increase access to these services, and reduce stigma around health-seeking behavior. We had more than 298 life-saving interventions for students that were at imminent risk of attempting suicide. So that's almost 300 students in Utah that are still with us today because of the services in Safe UT. When we look at the school safety or school tip feature, we see that the leading tip that's submitted far and away is concerns of suicide. But our second tip that's submitted is about bullying, and then subsequently potential school threats or acts of violence. So in the 2020 to 2021 school year, we had 256 planned school attacks or potential threats of violence that were reported and prevented from taking place because of the collaboration with our mental health professionals, school administrators, and law enforcement officials when it's necessary. So we have more than 850,000 students in the state of Utah with access to the app. That's almost 95% of our public schools, 90% of all of our schools in the state that over the last 7 years have opted in and chosen to be part of this incredible collaboration and life-saving service. We're happy to answer any questions and really commend the incredible work of Martha and her team and Representative Fleming on addressing mental health and school safety concerns in Kentucky.
Thank you all very much. I'm impressed. It's 256. That I was just commenting. That's an eye-catching amount of things that were thwarted potentially. That's obviously in today's environment and what we're seeing nationally is tremendous. So I appreciate that. Any other comments from you all? If not, if there's any questions or comments, Representative Bentley.
I have a question. 4 years ago, I had the same bill, and I used President Vickers from Utah, who's a good friend of mine, and we brought it up, and the state of Kentucky wouldn't supply the money. Remember that, Kim? Or any support. Have you already talked to the cabinet or any of them to get support?
Thank you, Representative. Let me just sort of explain how that's going to work. Basically, what we're doing is that we're talking to foundations here locally, and U of L Peace is going to help provide the personnel and costs to provide those mental health counselors. Then through very strong relationships we have, and we got pretty good commitments thus far from a foundation to help provide money initially get this thing going. And then when it comes to the spring, as I mentioned, I'm going to introduce the bill. We're going to basically help complete the funding of this next year, and then in addition to that, set things up for full implementation and full funding the following, which is the second half of our fiscal year.
You have a call center already?
I'm sorry?
You have a call center already?
This is U of L Peace. That they will be providing that. And it's not really a call center, but it's going to be mental health professionals that will provide this. Martha, do you want to explain a little bit?
Well, so through the smartphone and through the, as we work with University of Utah and building the app for Kentucky, we would have 24 hours a day, 7 days a week, a licensed therapist on the other end to answer the calls or texts or chats coming in.
Thank you.
You're welcome.
Thank you all. Well, very good. It's an exciting topic, and I know it's been out there for a while, so I appreciate you all bringing light to this, and hopefully we'll see some legislation moving in the upcoming
well, thank you. And I want to compliment, just call out Utah and Rachel and her group. They've been very, very instrumental. They're going to basically hold our hands and walk this whole thing through so we can make sure we have the best service out there as possible. So we're really excited about this. Once again, this is a life-saving measure. It starts with mental health. And to prevent any type of suicide issues, depression, anxiety for the kids. It's all about the kids, the parents, and the teachers to make sure we take a holistic approach to make sure we elevate everybody's mental health.
And Chairwoman Mosier was just mentioning we fund poison control centers in this state through Norton's, I think, and that's in our budget every year, and I think it's something we need to start considering also on this topic moving forward. All right.
Thank you, Rachel.
And the other question that I think also needs people, 988 is a new number we've got for mental health. Does this tie into that at all? I mean, as far as an opportunity, or is it going to be completely separate, or has there been discussions about that?
There has been discussion about it. We'll continue to talk about it, but it's going to augment it. It's going to complement that, what they're doing. I know Senator Wise was here, but, there's a bill we passed several years ago, the School Resiliency Safety Act. In there, and in one of the sections, it talked about using different tools. One of those different tools that's mentioned is mobile, and this is what this falls into the play and so forth. So I really think it's going to be very much of a complementary. In fact, it's going to enhance, because remember 988 in a tough situation, or remember the suicide line. It's hard to remember those numbers. All you gotta do is look at your phone, and you hit it, and you're gone talking to somebody. That's what it takes. It's an easy access.
Thank you all so much. Appreciate the presentation. Look forward to that in the upcoming session. And we have one more presentation briefly on healthcare workforce shortages. I know the Nancy Galvani and Betsy Johnson are here regarding a topic that I think that is front and center for us right now in healthcare. So if you both would like to come forward, introduce yourselves for the record, and give us an update on where we stand with regards to our workforce situation in healthcare.
I'm Nancy Galvani, President of Kentucky Hospital Association.
And I'm Betsy Johnson, President of the Kentucky Association of Healthcare Facilities.
Okay. Well, I just want to thank you, Chairman Alvarado, Chairwoman Mosier, members of the committee for having us today. And so I'm just going to cut to the chase. The bottom line for hospitals is that our costs are skyrocketing. Healthcare workers are retiring in large numbers, and not enough people are entering into the health professions to meet the growing need. And so the crisis, as you all know, has been in the making for a while. COVID-19 exacerbated it, and of course there's no quick fix. So where are we today? Kentucky Hospital Association just completed a workforce shortage survey. And with nearly every Kentucky hospital reporting, we know there's a shortage of 5,391 RNs and LPNs just in Kentucky hospitals. The vacancy rate is most acute for nurses working in medical surgical units where there's a 30% vacancy rate. And of course, while the need for nurses is most acute, there's also a shortage for virtually every other type of healthcare worker in the hospital. Our hospitals continue to rely on travel nurses to staff hospital units, and as we've said in previous testimony, those come at a national rate of pay, and that's because there's a national nursing shortage, and Kentucky hospitals are competing with other wealthier states for the same labor pool. The amount of money our hospitals are spending on travel nurses and premium pay, which is higher wages paid to your existing staff, is growing exponentially, and it's jaw-dropping. We just did a survey of our hospitals, and we found that in 2019, Kentucky hospitals spent $88 million on nursing contract labor. And in just the first 6 months of 2022, that number has skyrocketed to $489 million. That's $400 million more being paid for travel nurses just from January through June. That's an increase of 455%. Nursing premium pay has gone from $50 million in 2019 to $185 million just from January through June of this year. That's a 269% increase in premium pay for nurses that are already working in the hospital. So how are hospitals surviving? You're probably wondering. The existing Medicaid ATRIP inpatient program has been vital to help hospitals meet these enormous costs. There's no state funds involved in that program, and we are interested in expanding it to outpatient services. So clearly, these staffing costs are not sustainable, but again, there's no quick fix to the crisis. We know it's going to take time to increase enrollment in nursing programs and to get graduates from those programs. We know that there were 5,067 enrolled students in ADN and BSN programs during 2019 to 2020, that academic year, and 3,211 ADN and BSN students took the NCLEX test in 2021. And that's a gap of nearly 2,000 individuals between enrollment and testing. And not everyone that tests is going to pass or pass on the first try or pursue employment in bedside care. Further, more than 18% of hospital nurses are expected to retire over the next 10 years. And that number is even higher for psych nurses, the percent is 36%, and OR and recovery nurses, nearly 28%. With more experienced nurses retiring, fewer entering the workforce, we have an aging population, the stress on the healthcare system is going to demand creative solutions. We are very eager to work with educators at all levels to interest middle and high school students into health careers, to explain to them and to their parents that health careers offer great pay and often their education can be paid for. Our friends in higher education need more funding to advertise and promote programs and resources that are already available, but we think a lot of people don't know about. We also think it would be very beneficial for educational authorities to increase the number of high schools offering health career training so that students have the opportunity to earn certificates and sit for national exams, including LPN training at the high school level. This would allow students to enter the workforce immediately and then further advance their career through additional training. We're just eager to be your partner. We want to thank you for inviting us today. We know you've had a long day, and we're here to answer any questions. Thank you.
Do I need to pull up my presentation, or is it?
Sure, if you like. The floor is. I don't think we have a presentation.
No. It's not there, but you didn't send us.
I don't think we have a copy of it.
Okay. Yeah, I sent it to. It was sent to Deanne, but it's fine. It's fine. We'll make sure that you all have it. So first of all, we stand with our partners at the Kentucky Hospital Association. If our workforce is not working, then there are people in the hospital that should be in skilled nursing facilities because we cannot admit new residents when we don't have the sufficient workforce. It was interesting that there's a lot of mental health talk about today, because one of the reasons why we're struggling is because our workforce is having mental health issues. There's burnout, post-traumatic stress disorder from COVID-19, retirements, childcare issues, transportation issues. And then, of course, we are competing with non-healthcare sectors that can raise their prices and pay their workforce more, because we are very Medicaid dependent. I heard Commissioner Lee say yesterday that 70% of the Medicaid 70% of residents are covered under Medicaid, and as you all know, that's the lowest payer. We are also dealing with the Medicaid rates that have not kept up with increased costs. Currently, the federal government is threatening Medicare cuts to skilled nursing facilities, and of course, President Biden has indicated that he's going to have a mandatory staff ratios for skilled nursing facilities, and we simply don't have the workforce to comply with that. When you do get the presentation, we have slides that show some quotes from some of our members indicating the costs that they have expended to do geofencing and other things to try to attract workforce, and to little or no avail. We also have, and I'm trying to go fast because I know you all are tired, and I want this to stay on your radar. I don't want y'all to get not understand the importance of this issue. There's been a significant decline in nursing home employees. We have lost 4,347 jobs since the beginning of the pandemic of March 2020. And that's just skilled nursing facilities, the entire long-term care industry, which in Kentucky is also assisted living and personal care, there has been a job loss of 5,505 individuals of jobs. And then I have a really great graph, and I meant to talk to Nancy about this beforehand. I wish you could see this. I'll make sure you get in front of you. We are, according to the Bureau of Labor Statistics, the only sector in healthcare that has not recovered at all in our workforce. Ambulatory services have increased 4.2%. Hospitals, according to the Bureau of Labor Statistics, 0.4%. We are at negative 16.1% of our workforce. And for those of you all who have been in a nursing facility, it is a calling. We have a hard time attracting people. And I agree with Nancy. We need to start at the high school level. I just had a board member tell me that the one person that was doing training for medication aids in the community college in Northern Kentucky left. So we have nobody that's going to be able to train for medication aids up at Northern Kentucky through the community college system. So we have to figure out how to get training for high school students. A lot of jobs in long-term care do not require a college degree. You can get certified right out of high school. So I would like to work with the Hospital Association and with you all on that issue. And also, we appreciate the passage of House Bill 282. We work closely with the Hospital Association on that. Staff agency use has just skyrocketed since the pandemic. Costs are unaffordable. We have, that law just went into effect recently. We're going to be tracking it very closely. We're encouraging our members to file price gouging complaints with the Attorney General's office if that's what they're seeing. And meanwhile, we want to work with our staff agencies to ensure that they're charging appropriate rates, but also to get these people back as employees of long-term care facilities, because we know continuity of care means the world for quality healthcare services. So I spoke really fast, but I want to make sure that you all got that information before we leave.
Thank you. I speak fast too, so everybody knows that. I'll tell you that, of all the topics we heard about today, this is probably going to be the thing that's most front and center. We're all used to showing up to an ER and having someone take care of you. Something happens. That's what we're used to in America. We're used to that in our state and our communities. And I remind everybody, this is a team effort. That when we have healthcare anymore, that doctors that do surgeries need to have surgical techs and have to have nurses in the room and have to have other people, support staff, to be able to do those surgeries. The time is coming very soon. If you start seeing everybody exiting quickly and more than we have coming in, or if you have to have a surgery done, a procedure done, something done to work up a potential tumor or potential cancer or something that's risky for your loved one. Or placement of a loved one. I can't take care of somebody at home. I need to have a facility for them to go to. Those days are coming quickly to an end, and that we're going to say, I have nowhere to send somebody. What am I supposed to do? and it's going to be, we're full. We have no more room. And it's not dependent on how many physical beds. People talk about healthcare being a right, and they think it's talking about a bed or an IV tube. Healthcare is ultimately professionals and people with knowledge and skills. And we don't necessarily have the right to someone else's labor. If they're not, we fought a war over that issue. And there's a lot of people out there that have these abilities that are saying, I'm done, I've had enough. Because we've relied on the goodwill of a lot of these folks to make the system work, and that goodwill is quickly escaping us. So this is the biggest topic, I think, one of the biggest issues at hand in our state and in our country when it comes to our healthcare system. We've got a couple of questions. Senator Nemes.
Yes, thank you for being here and talking very quickly. We could talk on this all day, maybe all week, because we're having not only shortages in the healthcare, shortages in everything, welding, anything. So we need to focus on training our own with our own people, because I don't see how you're getting, with a national nursing shortage, I don't know how you're getting travelers. Even the construction trades can't get travelers coming in to build things. So the high school focus is fantastic. That's what we need. The funding is not the answer. I'm not saying you don't need funding, but the people is the answer. We have to get the people. Have y'all looked at the Nortons, what Norton's has done with the registered apprenticeship, how they are training their people? Because that offsets somewhat, that gets a high school student or other people into the programs, because then we don't need state funding. The hospital is funding that, and they're paying the people as their registered apprenticeship, which Norton's helped Kentucky start the first registered apprenticeship for healthcare, more than just nurses, others. And then this administration pushed them away, so they had to go straight to the feds for it. We need to emulate that kind of stuff. You talk about EMT. Bullitt County did the same thing with apprentice and bringing people in. And the only problem we're having in Bullitt County with our EMTs is people are taking our trained, which we train them, taking them away from it, paying them more. So that's something I think you need to focus on. Sorry, Mr. Chairman, I'm trying to talk fast, but I think we do have alternatives. It's going to take time. Thank you.
Thank you. Senator Carroll.
Thank you all for the presentation. How much of this crisis has been created by having clinics on every corner? And from the hospital perspective and just from the industry as a whole, I mean, over the last 20 years, I don't know what the numbers are. I'm sure they're huge, that there are clinics everywhere, which takes extra staff to be able to run the clinics. Therefore, it creates a shortage within the hospitals. So sometimes do hospitals hurt themselves by continuing to open clinic after clinic that requires more staff? Because I would venture to say that the hospitals are the hospital organization are probably serving more people with more staff because of all the clinics, but yet there's a shortage within the hospital. Help me understand that relationship in these studies.
So I think what you're seeing is an aging population. There's a demand for more services. And so, yes, people are wondering, well, how are hospitals opening more services? What's to meet their patient needs? But staffing is obviously an issue. Now, the people that are working in a hospital, they're very highly trained. The nurses that, depending upon the unit you're working in, if you're labor and delivery, you're very highly trained in that, or, cardiac cath, or, ICU, versus, maybe in a clinic, it's a different skill set. But hospitals, are opening these additional services because there's unmet need, and we're an aging population, and unfortunately, we need care.
I think sometimes maybe we look at it in a way that, it's not really because we're falling behind over what we've had, the care that we've had to provide in the past. We're not keeping up with what you just said with the future demand. And so that's really, and it just came to light the other day. My wife comes from healthcare field. We're driving around. There's 2 or 3 clinics going up, and we started talking about that, and it made perfect sense that does help create part of the shortage issue. Thank you. Thank you, Mr. Chairman.
Thank you. Senator Meredith.
Thank you. Very briefly, appreciate your presentations as always, and particularly in the rapid fire manner that you delivered it. But I don't want you to think that we're discounting the importance of this. I know, Nancy, we've got you scheduled, I think, to meet with our budget review subcommittee for human services to talk about the enhanced reimbursement for outpatient services. And the reason it's coming to budget review is it's going to require an appropriation, which is kind of a technicality. And Betsy, I think we've got you pegged for Medicaid oversight to presentation sometime in the next month or 2 months. It's obviously going to have impact on our Medicaid program. So you'll have an opportunity to deliver it in a much slower fashion. But appreciate you being here today.
Thank you.
Thank you. All right. Well, again, this is a hot topic, and I'm sure it's going to be front and center for us going into the next 3 to 4 years until we start seeing hopefully new graduates coming through nursing programs, et cetera. Our next interim joint meeting for Health, Welfare and Family Services is going to be on Thursday, August the 25th, 2022 at 1 p.m. at the Kentucky State Fair in Louisville. Hopefully we'll see you all there. If there's no other matters before this committee, we stand